Ricky, Hannah, can you hear me okay? Just want to make sure my audio is working.
Yes.
Yeah, I can hear you.
Thank you.
Can you guys hear me?
I
Yeah.
can.
Perfect.
Hey, everybody, good afternoon, and welcome to the sixth webinar of 2022 in the ACCP Immunology and Transplantation PRN webinar series. My name is Ricky Evans. I am a lung transplant pharmacist at University of Kentucky Healthcare, and it is my pleasure to moderate today. Today, we'll be providing a recap of the 2022 ISHLT annual meeting, and we are honored to have three excellent speakers with us today. Our first speaker will be Hannah Underwood, who is a lung transplant pharmacist at UK Healthcare as well. She completed her PharmD training at the UK College of Pharmacy, her PGY1 residency at the University of Illinois at Chicago, and her PGY2 in solid organ transplant at New York Presbyterian Hospital. Our second speaker will be Olivia Huber, who completed her PharmD at the University of Rhode Island. She did her PGY1 residency at Henry Ford Hospital and is currently the PGY2 SOT resident at Tampa General Hospital. Following her PGY2, she will be starting as a heart transplant pharmacist at University of Wisconsin Health. And our final speaker will be Rachel Cartus. Rachel is currently a heart transplant and MCS clinical pharmacist at Keck Medicine of the University of Southern California. She obtained her PharmD from the University of Pittsburgh and completed both her PGY1 and PGY2 SOT residencies at the Johns Hopkins Hospital in Baltimore, Maryland. In a moment, I will turn it over to Dr. Underwood to begin the presentation, but first, here are a few quick notes. For our audience members, please ensure that your microphone remains muted for the duration of today's presentation. The mute button is located in the lower left-hand corner of your screen. If at any point in time during the presentation you have a question for the speaker, please submit your question by using the chat functionality at the bottom of your screen. Please send your questions directly to the moderator of today's webinar to minimize possible interruptions. We will answer and address all questions at the end of today's webinar, but feel free to submit your questions to the moderator at any point in time during today's presentation. Today's webinar will also be posted on the ACCP IMTR YouTube channel if you would like to view the recording. If you experience any technical difficulties during today's webinar that are not fixed by logging out and refreshing your internet connection, please make sure to notify the moderator right away through the chat functionality. Now, without further ado, I will turn it over to Dr. Underwood to get us started.
Thanks, Ricky, and thank you to the IMTR PRN for having me today. As Ricky stated, my name is Hannah Underwood, and I am a clinical pharmacist in lung transplant at UK Healthcare. I'm excited to provide a few highlights of data presented at the ISHLT 2022 meeting in April related to lung transplantation. To get us started, I wanted to first discuss a presentation given by Dr. Georgina Waldman from Massachusetts General Hospital. This presentation discussed the non-induction use of basiliximab for calcineurin inhibitor holiday. As we know, basiliximab is a chimeric monoclonal antibody which blocks the alpha chain of the IL-2 receptor complex that is expressed on activated T cells. IL-2 receptor binding is not irreversible and is maintained as long as drug levels exceed 0.2 nanograms per milliliter. Within 1 to 2 weeks after concentrations fall below this cutoff, the number of T cells with unbound IL-2 alpha returns to pre-dose values. Understanding both the pharmacokinetic and pharmacodynamic properties of basiliximab allows us to understand the 30 to 45 days of IL-2 receptor saturation denoted on the package insert when utilizing 2 doses for induction therapy. In understanding this information, this allows us to consider how we may use basiliximab beyond the package insert in lung transplant recipients. Here on the slide, I present data by Eiting and colleagues of a case-matched cohort study of CNI holiday for adverse effects, including renal and hematologic toxicities. This study cohort matched a cohort of 22 patients in each group. Basiliximab at a dose of 20 milligrams was administered at the time of toxicity and redosed at 20 milligrams if needed 14 days later. In majority of the cases, the offending agent was calcineurin inhibitor only. However, 3 patients in the basiliximab cohort were a combination of a calcineurin inhibitor and mTOR inhibitor. The primary endpoint of the study was rejection-free survival at 6 months post-intervention, and additional endpoints included recovery from CNI toxicity, infection, and progression to bronchiolitis obliterans syndrome. The results of this study showed that the basiliximab group experienced lower rejection-free survival at 6 months, as denoted in the figure 1 on the right, at 64% versus 91% compared to the case-matched group. The basiliximab group also experienced more infections at 6 months, majority of which were considered to be pneumonia at 95% versus 82%. The conclusions from this study noted improvement in long-term toxicity recovery with interim CNI holiday using basiliximab. However, we must weigh the increased risk of rejections against these benefits. Future research is still needed to understand the need for repeated dosing, as well as the opportunities for additional modification of non-CNI immunosuppression during the CNI holiday strategy. The next presentation I would like to discuss was by Dr. Jan Goldlieb from Hanover Medical School regarding the 5-year long-term results of the FOREVER lung study. Everolimus-based quadruple immunosuppression has been shown to be effective in preserving short-term renal function without compromising efficacy or safety after lung transplantation, as noted in the FOREVER lung study at 12 months. Results of the initial study demonstrated superiority of the quadruple low CNI regimen for their primary endpoint of estimated GFR after 12 months. The aim of the 5-year follow-up of the FOREVER lung study was to assess both efficacy and safety of an everolimus-based quadruple low CNI immunosuppression compared to standard triple therapy up to 5 years after randomization. Complete data set in this study was available for 123 participants from 6 centers. 56 or 46% were initially randomized to standard triple therapy, and 66 or 54% to quadruple low CNI regimen. Over the 5-year study period, regimen switch occurred in 41 patients, and most commonly, the switch was from quadruple therapy to standard triple therapy. The analysis in the long-term follow-up looked at both the intent to treat population, as denoted in figures A, and the per population population, as denoted in figures B. In this retrospective analysis, estimated GFR at 5-year follow-up did not differ between groups in both the intent to treat and per protocol population. Thromboembolic events occurred more frequently in the quadruple low CNI regimen, and there was no difference in the endpoints of graft survival or clade-free survival between the groups. In addition, 1/3 of the patients who switched the regimen before study completion had worse graft survival at 5 years than those patients who remained on their initial regimen. The authors concluded that initiation of an early everolimus-based quadruple low CNI regimen had no long-term benefit on renal function after 12 months. However, the safety and efficacy profiles appeared comparable to our standard triple immunosuppression regimen. There is still need for further investigation to determine how mTOR inhibitors can be utilized for long-term renal function benefit post-lung transplant. The next presentation I would like to discuss was by Dr. Arya Caffey, a lung transplant pulmonologist at the University of California, San Diego. This study was discussing the use of Hep C positive organs for lung transplantation. From the literature, early studies have shown direct-acting antivirals may be safely used and lead to sustained virologic response, or SVR, without any difference in survival at 6 months post-transplantation. However, there may be an increased risk of acute cellular rejection. Direct-acting antiviral agents for the treatment of hepatitis C have increased the donor organ pool for lung transplantation. The aim of this group study was to assess whether there was any difference in acute or chronic rejection rates at the 1-year mark from HCV infected donors. A total of 76 patients were assessed in the study, 15 patients being from Hep C positive viremic donors. Majority of these patients received bilateral lung transplants and induction with basiliximab. The most common genotypes were genotype 1, 1A, and 1B, and all 15 patients became Hep C NAT positive. The median days to direct antiviral initiation was 20 days, and all 15 patients were able to achieve sustained virologic response. The most common hepatitis C medication used for direct acting antiviral was Mavorite, although 1 patient was treated with Epclusa and 3 patients with Harvoni. The results of this study showed that the rates of rejection were similar between the 2 groups. 2 patients in the Hep C positive viremic group had ACR A1, none had AMR, and none had CLAD. In the Hep C negative donor group, 2 patients had A1 rejection, 2 patients had A2, and 1 had AMR. This study reports a single center experience using Hep C viremic organs in lung transplantation treated with our direct acting antiviral. The follow-up of this study was 1 year, and therefore longer term follow-up is needed. However, this study appears that there can be a safe way to increase allocation of lungs and reduce waitlist mortality by utilizing Hep C positive viremic organs. Further studies, although, are needed to determine long-term safety and efficacy. The last topic that I would like to discuss is the use of belatacept following lung transplantation. Renal failure is a major cause of morbidity and mortality after lung transplantation, and exposure to nephrotoxic immunosuppressant drugs further potentiates this risk. I would like to review a presentation given by Cody Moore from UPMC Presbyterian Hospital discussing both the current data of belatacept use following lung transplant, as well as future directions and concerns. I first want to quickly review the previous data published on belatacept use following lung transplant for renal rescue. The first study by Tomasi and colleagues was published in 2016. This was a case series of 8 lung transplant recipients at a median post-op day of 585 days who were initiated on belatacept after developing renal insufficiency in combination with low-dose calcineurin inhibitors. Our target blood trough concentrations was generally decreased to 2 to 6 nanograms per ml for tacrolimus, 4 to 6 for sirolimus, and 75 to 100 for cyclosporin. The results of this study showed an increased median GFR from baseline, which was 24, to 28 at 1 month, 31 at 3 months, and 36 at 6 months after belatacept initiation. There was a trend towards improvement in creatinine values from baseline as well. 2 patients were successfully weaned off of renal replacement therapy that were initially on dialysis between 6 and 13 days after belatacept initiation. All patients in this cohort had a similar FEV1 at 6 months after belatacept initiation. There was 1 episode of acute cellular rejection, and 5 of 8 patients had infections post-conversion, 3 of which were prior isolated pathogens and 2 of which were new pathogens. Based on the results of this study, the authors concluded that belatacept combined with CNI reduction warranted further study to confirm safety and efficacy and management of our lung transplant recipients. The second study that I've included is by Benninger and colleagues. It was published in 2021. This study is a prospective cohort study that included 85 lung transplant recipients at a median of post-op day 293. The patients were initiated on a belatacept dose of 10 mg per kg on days 1, 5, 14, 28, 56, 84, and then monthly thereafter. This was combined with low-dose tacrolimus, which was defined as a goal of 6 to 8, less than 1 year from transplant, and then 4 to 6 at greater than 1 year from transplant. The results of this study showed a median of 1 ml increase in GFR, as well as 2 of 2 patients being discontinued on renal replacement therapy. The authors also noted a FEV1 increase of a median of 85 ml. It is also important to note from this study that 34 or 40% of the patients had CMV reactivation post-initiation of belatacept versus 22 or 26 pre-conversion. 34 or 40% of the patients discontinued belatacept infusions, 15 of which were due to CMV anemia or concern for CMV reactivation. The final study that I want to discuss is a retrospective case series by ISHLT and colleagues, which looked at 11 lung transplant recipients assigned to either conventional or transitional belatacept conversion dosing, as denoted on the slide. The median follow-up time in this study was 136 days post-conversion. The results of this study showed no difference pre and post-conversion in the composite rejection standardized score and infection incidence. There were 2 instances of severe invasive aspergillus infections, one of which patient had a previous aspergillus infection. Estimated GFR was significantly improved at 32 versus 45 in the pre and post conversion. The authors concluded that belatacept appears to contribute to improvement in estimated GFR without a rapid decline or loss from ACR. However, larger prospective trials are warranted to continue to define the role of belatacept in lung transplant. This leads me into the next study recently published by Wang and colleagues. This study is a recent randomized 2-center pilot study that compared de novo belatacept versus standard of care in combination with thymoglobulin induction. This protocol included thymoglobulin induction of 1 milligram per kilo for 3 days starting at post-op day 0. 13 patients were randomized to the tacrolimus plus belatacept plus prednisone arm from days 0 to 89, and then transitioned to belatacept plus mycophenolate mofetil plus prednisone from days 90 to 365. The first dose of belatacept was given after transplant on day 0 at a dose of 10 milligrams per kilo, and subsequent doses were given as a dose of 10 milligrams per kilo on days 7, 14, 28, 56, and 84, and then subsequently dropped to a dose of 5 milligrams per kilo. 14 patients were randomized to the standard of care, which included tacrolimus, mycophenolate mofetil, and prednisone from days 0 to 365. The primary endpoint of this study was to determine the feasibility of carrying out a phase 3 randomized control trial. This study enrolled from January to May and was permanently halted after 3 deaths in the belatacept arm versus no deaths in the standard of care control arm. These deaths were attributed to COVID-19, restrictive allograft syndrome, and hemothorax. After the study was halted, all other patients were converted back to standard of care. 2 additional patients in the belatacept arm died after conversion to standard of care. These were denoted as pulmonary embolism and PTLD. There was no difference in ACR episodes or DSA formation, as well as no difference in infection incidence determined in this study. The takeaway from this belatacept session is we still have unanswered questions regarding how and when to use belatacept following lung transplantation. While we have a few reports of improved renal function with combination belatacept and low-dose calcineurin inhibitors, further investigation is still warranted for long-term safety and efficacy measures. Based on the recent study published by Wang and colleagues, de novo belatacept use is not recommended at this time. Going forward, we still have many questions to answer regarding the optimal dosing regimen of belatacept and concomitant immunosuppression, as well as the risk of infection, ACR development, and the potential impact on DSA. I want to thank the IMTR PRN again for allowing me to join the webinar today, and I will take any questions at the very end of this session. Thank you.
Okay, sorry about that. I guess you cannot unmute after you control the slides. My name is Olivia Huber. I will be talking about updates in heart transplant from the ISHLT Recap meeting. For this presentation, I will be utilizing some of these abbreviations, which are available to you here on this slide. My objectives today are to review updates in induction and maintenance immunosuppression in heart transplant, as well as to evaluate cardiorenal metabolic therapies and their effect on patient outcomes. First, I just wanted to address and highlight the fact that there was a symposium regarding updates to the 2010 ISHLT guidance on the care of the heart transplant recipient. There were 4 task forces assigned to reviewing and updating the guidelines. The updates are too extensive to cover adequately during the session, so instead I just chose to highlight topics that have been either added to the newly proposed guidelines or significantly updated for your review. The task forces 1, 3, and 4 are reflective of newly added topics, and task force 2 is reflective of sessions which have had extensive updating but are not new. So for task force 1, perioperative care, they expanded pre-transplant optimization, including frailty, vaccines, and hemodynamic optimization, and also patients bridged with mechanical circulatory support. They also expanded information on primary graft dysfunction, considerations for multi-organ recipients, vasoplegia, and care of recipients with CHD. For immunosuppression and rejection, they significantly updated rejection surveillance, non-invasive surveillance, immunosuppressive regimens, AMR therapies, and late AMR. For management of complications, they added arrhythmias, anticoagulation after heart transplant, and monitoring recipients from donors at higher risk of infectious disease, as well as expanded information on imaging modalities and immunosuppression minimization. And for prevention and prophylaxis, added information on substance use, family screening, traveling after heart transplant, and of course, a section on emerging pathogens and pandemic considerations. They also provided updates for nutrition and weight management and psychosocial issues. Starting off with updates in induction and maintenance immunosuppression, we will begin by looking at a study conducted by Dr. Louise Holzhauser at the University of Pennsylvania. There are many considerations in heart transplant recipients, whether to use an induction agent or not, and induction therapy is currently utilized by about 40 to 50% of centers. Induction therapies like basiliximab have the advantages of delaying initiation of nephrotoxic immunosuppressants such as CNIs and have a benefit in high-risk patients. However, they also confer a risk for infection and malignancy. This study sought to define the risks and benefits of IL-2 induction when used both as a standardized induction agent in all patients versus later on as a selected agent for a renal sparing protocol. This was a retrospective single-center cohort study of consecutive heart transplant recipients from 2003 to 2020. They excluded patients who underwent multi-organ transplant, retransplant, or those bridged to transplant with a left ventricular assist device. Due to an institutional policy change in 2016 away from routine basiliximab use, they started a CNI sparing protocol in select patients, and therefore they stratified some of their data from 2003 to 2015, and then another subgroup from 2016 to 2020. They included 475 patients with 284 in the basiliximab group and 191 in the no induction group. In the overall cohort, there were no clinically significant differences in gender and age between the two groups, although the basiliximab group patients had a lower baseline GFR than the non-basiliximab group, as well as a higher overall PRA. In the overall group, when adjusted for co-founders of sex, age, PRA, and GFR, the basiliximab group was less likely to have acute cellular rejection, but had more antibody-mediated rejection and more cardiac allograft vasculopathy at 5 years post-heart transplant. There was no difference between basiliximab group and non-basiliximab group in ejection fraction, DSA, malignancy, or infection. When they stratified the data by the era, so 2003 to 2015 versus 2016 to 2020, acute cellular rejection remained less common in the basiliximab group, while AMR remained more common. In the pre-2016 group, the basiliximab group had more DSA. Notably, there were no significant differences in survival comparing pre and post 2016 in the non-basiliximab group. However, both pre and post in the basiliximab group have significantly higher mortality during post-transplant years 1 through 5. In summary, there are a few major takeaways from this study. When adjusted for co-founders and stratified by era, the basiliximab group was less likely to have acute cellular rejection, but had more AMR and cardiac allograft vasculopathy. There was no difference between basiliximab and the no induction groups in left ventricular ejection fraction, malignancies, or infections. There was no significant difference in survival comparing pre and post 2016 with no induction, but in the basiliximab groups, they both had significantly higher mortality. The study authors did notice that they had a limitation of having a 17-year study where there was multiple protocol changes over the years, and they also had a pretty low incidence of both DSA and AMR. This also posed the question, does basiliximab lead to more AMR and cardiac allograft vasculopathy? And more studies should be done to address this as well. Next, we will move on and discuss some new data regarding maintenance immunosuppression. This study was presented by Dr. Mihail Kincharla of Toronto General Hospital. The purpose of this study was to investigate sirolimus and everolimus on rejection and renal function based off of their drug levels. The study design was chosen because despite knowing that our mTOR inhibitors can have beneficial effects on renal function, risk of malignancy, and CAV, there is less data addressing the fact of actual drug levels specifically on these outcomes. The study investigators hypothesized that lower levels of PSI or mTOR inhibitors will improve renal function, but might increase the risk of rejection and death, which was a composite endpoint. This was a retrospective cohort study of 99 heart transplant recipients who were on tacrolimus and initiated on an mTOR inhibitor with tacrolimus minimization at any time after 6 months post-transplant. They separated the patients into 3 groups based on their relative drug levels after mTOR initiation. So post-initiation, they looked at the combined levels and expressed them as a % increase or decrease in total combined level at 1 month in reference to the tacrolimus level prior to initiation. The decreased group had greater than 15% decrease in level. The increased group had increased 15% or more in level, and the stable group was in between a 15% decrease and increase. The study found the mean age was 53 years old, and 25% of the patients were female. Based on relative drug levels pre and post initiation, 9 had decreased levels, 15 had stable levels, and 75 had increased levels. The baseline was not significantly different between the groups in terms of baseline characteristics. There were 3 main reasons for mTOR initiation. 65 were for CAV, 16 for renal function, 14 for cancer, and 5 for clinical trials. At 1 month, the decreased drug level group had a 47% increase in GFR versus the 10% GFR increase in the stable group and 4% in the increased drug level group. And overall, risk of rejection and death at 1 year were not significantly different between the drug level groups. Lastly, we will discuss a study focusing on the incidence of mTOR inhibitor-associated bronchiolitis obliterans organizing pneumonia, also known as BOOP. This study was presented by Dr. Ronald Zulte from the University of Nebraska Medical Center. This study investigated the incidence of mTOR inhibitor-associated BOOP on patients who were initiated on an mTOR inhibitor to either delay progression of CAV or for renal function. In a previous study, this center reported a 24% incidence of 7 out of 29 patients of BOOP when converting from a calcineurin inhibitor to a sirolimus-based regimen. Upon further investigation, there was no underlying infection found in any of these 7 patients. They hypothesized, based on this data, was that the removal of a calcineurin inhibitor was permissive for BOOP. They decided to repeat the study since the immunosuppression protocol had changed, and now the center maintained tacrolimus levels between 0 to 4 and a sirolimus between 8 to 12 and everolimus 7 to 11. The primary outcome of the study was incidence of BOOP, and they also looked at timing of mTOR inhibitor conversion post-transplant and associated tacrolimus concentrations. During the study period, none of the 61 included heart transplant patients developed BOOP. Late mTOR inhibitor transition greater than 1 year post-transplant was more common. The early conversion and sirolimus was more commonly utilized than everolimus. Following that mTOR inhibitor conversion policy, all patients were maintained on low-dose tacrolimus at initiation, and at 1 year, 84% of the patients were still on concomitant tacrolimus. They concluded that no patients at their center experienced mTOR inhibitor-related BOOP while maintaining a low-dose calcineurin inhibitor. The results of the study suggest that calcineurin inhibitors may have a protective effect from BOOP even at low concentrations. And they saw no increased rate of rejection with mTOR inhibitors plus calcineurin inhibitor compared to a high rejection rate in that original study where the patients were not on a calcineurin inhibitor. Next, I'll move on and briefly discuss cardiorenal metabolic considerations post-heart transplant, as there were multiple studies presented on this topic. First, I would like to highlight a talk given by Dr. Amanda Vest from Tufts Medical Center. The strides that we've taken to improve post-transplant survival have mainly improved the first 6 months. However, longer-term survival after heart transplant has not budged as much. The leading causes of death more than 10 years post-heart transplant, in addition to malignancy and infection, include graft failure, CAV, and renal failure, which all fall under the cardiorenal metabolic umbrella. 21% of recipients develop post-transplant diabetes within the first 5 years after heart transplant, and this could down the line lead to more renal dysfunction, CAV, and decreased graft and patient survival. Patients who have pre-transplant diabetes mellitus have the worst renal and mortality outcomes, followed by those who do not have diabetes pre-transplant but develop post-transplant diabetes within 5 years. And then patients who do not develop diabetes have better outcomes. SGLT2 inhibitors, as we know, are protective against cardiovascular death and other cardiovascular events in the general population of patients with diabetes and with cardiovascular risk factors. But we do not know whether those effects are experienced by heart transplant recipients with diabetes as well. We also know the data from our studies in heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. There have been studies looking at SGLT activity in rat models, and it has been implicated as a mechanism for tacrolimus diabetogenesis. When in trials an SGLT1 inhibitor was administered to mice following tacrolimus, the glucose transport in the intestine was blocked. Another study in animal models showed a twofold increase in SGLT2 expression with tacrolimus exposure, and the addition of empagliflozin decreased SGLT2 expression and limited histological renal injury. Initial first few studies of SGLT2 inhibitors in heart transplant showed many benefits, and practitioners are comfortable for patients to use with type 2 diabetes, CKD, or heart failure. But Dr. Vest postulated that maybe all heart transplant recipients should receive SGLT2 inhibitors, as they may have a protective effect on CNI nephrotoxicity and also may help to prevent CAB. We also know for our GLP-1 receptor agonists that from studies like LEADER with liraglutide and other GLP-1s can improve cardiovascular outcomes. And we've also seen renal protective effects from these trials. GLP-1 receptor agonists are also FDA approved for weight loss in some patients without diabetes. There is also data from a mouse model that liraglutide may attenuate cardiac allograft vasculopathy. Dr. Sundarravel at the University of Nebraska Medical Center presented on their experience using SGLT2 inhibitors after heart transplant. Due to detrimental effects that PTDM can have on infection risk, graft function, and patient outcomes, they looked at all patients who received SGLT2 inhibitors at their center. This was a retrospective chart review of all heart transplant recipients who received an SGLT2 inhibitor through November 2020. They included 26 heart transplant recipients. The median days from transplant to initiation was 780 days, and the median duration of therapy was 169 days. 16 patients were diabetic pre-transplant, and 10 patients had post-transplant diabetes. They saw a statistically significant improvement in average hemoglobin A1C, weight, and BMI after starting SGLT2 inhibitors. Furthermore, the improvement in weight and BMI were sustained at 1 year for the patients who had follow-up data. There was also a non-statistically significant trend towards improving renal function. In this study, there was one patient who experienced genital candidiasis, and there was no incidence of hypoglycemia, amputation, euglycemic decay, volume depletion, or hypotension. And 2 patients in the study were also able to discontinue insulin therapy after they started their SGLT2 inhibitor. Study authors concluded that SGLT2 inhibitors are safe and efficacious after heart transplant, and that the possible renal protection from CNI toxicity should be explored in larger trials. Another study by Samore and colleagues retrospectively evaluated the safety and efficacy of both GLP-1 receptor agonists and SGLT2 inhibitors in patients who had undergone orthotopic heart transplant at a high volume center. They included 21 patients who had been seen in a multidisciplinary cardiometabolic center for at least 2 visits. All patients in the study were on tacrolimus, and 57.1% of them were also on sirolimus. A third of them were on mycophenolate, and a third of them were on prednisone. The median time from transplant was 5.7 years, but 4 were in their first year post-transplant. All patients were treated with at least one of these agents, and some were treated with both. At the last follow-up, The median total daily insulin requirements decreased from 88 to 22 units. Nearly 30% of patients were able to discontinue insulin altogether. And of the patients who are able to discontinue their insulin, their baseline requirement was 40 units per day. Among 21 patients, they found significant weight loss, reductions in insulin use, hemoglobin A1C, and LDL cholesterol. The median hemoglobin A1C decreased from 7.5% to 6.6%, which was statistically significant. Mean body weight decreased from 247 pounds to 220 pounds, and BMI decreased from 36 to 32. There was also no difference in estimated GFR. Both classes of agents were well tolerated with no adverse effects that led to discontinuation of either therapy. They saw no DKA, no pancreatitis, and no genital infections. They demonstrated that SGLT2 inhibitors and GLP-1 receptor agonists appear safe and effective therapies among patients with type 2 diabetes after heart transplant. The study was limited by a small sample size, and larger trials should be conducted to confirm these results. The study authors also pointed out that the optimal time to start these agents after transplant has not been established. We know from previous studies that statins are recommended after heart transplant to reduce the risk of cardiac allograft vasculopathy and improve long-term outcomes regardless of lipid levels, but these can be poorly tolerated and also another pill for our patients to take. PCSK9 inhibitors can achieve decreases in LDL cholesterol greater than 50% alone or in combination with statins. They also have no increased risk of myalgia or liver injury. They have been shown in trials to decrease the risk of myocardial infarction, stroke, and revascularization in adults with ASCVD. The investigators in this study aim to evaluate the use of PCSK9 inhibitors in heart transplant. They looked at 65 patients who received a PCSK9 inhibitor and a median time from transplant of 5.5 years. IVUS data were available in 33 patients, and the median time of transplant for those patients was 6 years before and after therapy. After a median follow-up of 1.6 years, neither the maximal intimal thickness nor the luminal area significantly progressed in any of the 5 measured frames. This was true regardless of whether patients were on an mTOR inhibitor or not. There was also a 58% reduction in LDL cholesterol, and 72% of patients in the study achieved their LDL target. This effect was also sustained at the latest follow-up. And the data keeps evolving. There is an evolved trial that is currently going on. It's a randomized double-blind multi-center trial looking at evolocumab 420 milligrams monthly versus placebo. Their primary outcome is going to be maximal intimal thickness at 12 months. And their hypothesis is that evolocumab, when added to statin therapy, will significantly lower low-density lipoprotein levels in de novo heart transplant recipients. The overall goal of this trial is to determine whether evolocumab can ameliorate cardiac allograft vasculopathy in heart transplant recipients. Overall, newer data regarding long-term effects of basiliximab induction has come out, and also more data about mTOR inhibitor conversion in heart transplant recipients. And cardiorenal metabolic therapies are being investigated in heart transplant, including SGLT2 inhibitors, GLP-1 receptor agonists, and PCSK9 inhibitors. Thank you, and I can take any questions at the end of the presentation.
Hi, everyone. Thanks so much for having me today to discuss some updates and some new data presented on the mechanical circulatory support side of things from the ISHLT meeting this past April. So most of the major updates and presentations at the meeting this year surrounding MCS, I thought fell into basically 3 broad categories for the most part. So for this section, our objectives will be to just review some of this data, that was presented on heart failure therapies post-LVAD implantation, on therapies for GI bleeding in LVAD patients, and anticoagulation strategies, both in LVAD recipients and in patients who are on other forms of mechanical circulatory support. So one of the studies presented in the late-breaking clinical science section came out of the University of Ireland, Galway, and they presented their results from the Euro-Levos LVAD study, which utilized levosimendan in an attempt to prevent right heart failure following LVAD implantation. Just for a little bit of background, right-sided heart failure can occur in anywhere from 20 to 50% of patients who receive an LVAD. And severe right heart failure following implantation can really significantly increase mortality and ICU stay for these patients. So this study was a retrospective review of the EuroMax registry. They wanted to evaluate the effect of levosimendan on occurrence of right heart failure early on post-implantation, as well as length of ICU stay. They compared patients who received levosimendan to propensity-matched control subjects, and their primary outcome was early right-sided heart failure, which they defined as the need for a right ventricular assist device to be implanted within 30 days after LVAD implantation. Their secondary outcomes were ICU stay and then 30-day and 1-year mortality. So levosimendan is a first-in-its-class therapeutic inotropic agent, and it is not available for commercial use in the United States. As you may have guessed, as this was out of the University of Ireland, Galway, and why you might be a little unfamiliar with it. But this drug works as an inotrope, more in an unconventional way, by binding to cardiac troponin C, which enhances myocardial contractility, and without supposedly increasing myocardial oxygen consumption. It also works as a vasodilator through potassium ATP channels. So overall, its therapeutic effect is to increase cardiac output and stroke volume, and to decrease PVR and have a vasodilatory effect. And some of the advantages are thought to be it does not increase your risk of arrhythmia, and you can use it while patients are receiving beta blockers. Although the drug does have a short half-life itself, one of its parent metabolites does have a long therapeutic effect that peaks at approximately 80 or 90 hours after administration. So it's thought that it might have a very long therapeutic effect, although that can't be said of the parent drug itself. The authors of this study did indicate that the protocols used in different setters for this drug were highly variable. There was not a standardized protocol used, but doses mainly ranged from 0.05 to 0.1 micrograms per kilo per minute, and the drug was administered anywhere from 2 to 5 days prior to LVAD implantation for 24 to 48 hours. The authors did state that most of the centers did not bolus the drug, which largely seems to be avoided anyways in order to avoid any significant hypotension. So there were 5,755 patients identified in the EuroMax registry database, and the final cohort of patients who received the drug was almost 400, versus the cohort of patients who did not receive any levosimendan was 3,262. The authors actually did two analyses. They did both an adjusted regression with multiple imputation, logistic regression, sorry, and a propensity score matched analysis with multiple imputation. So as you can see here in the first two top rows, there were no significant differences between the two groups in terms of the need for RVAD implantation, both when a logistic regression done with adjusted for covariates and when they did their propensity score matched analysis. On the bottom, on the bottom row here, you can see that patients who received the drug did have a longer average ICU stay compared to patients who did not when they performed linear regression. However, this statistically significant difference did disappear once they appropriately adjusted for covariates. So overall, this study really did not demonstrate any advantage when they appropriately adjusted for covariates on both the need for RVAD implantation and ICU stay in patients who receive levosimendan following LVAD implantation. This seems to come after other trials throughout the years evaluating the use of this drug in some other patient populations. Doesn't seem like those have ever led to any significant mortality benefit. But I think this highlights overall that it's still important to present some data that's not significant and highlights, as the author stated, there's need for further investigation with an adequately powered study to warrant if this drug is beneficial in this patient population specifically. So next, I wanted to briefly discuss some presentations regarding the use of agents to prevent GI bleeds in patients with left ventricular assist devices. So for those of us who care for LVAD patients, GI bleeds and recurrent GI bleeds are a huge source of morbidity and rehospitalization. We know that patients supported by LVADs can have recurrent GI bleeding, likely due to a combination of factors: high shear stress, acquired von Willebrand syndrome, and the development of AVMs, all on top of the use of anticoagulant and antiplatelet therapy, can lead to a lot of issues. So while there were no randomized prospective data on any of these agents presented at the conference, at least to my knowledge, there was a systematic review and meta-analysis presented on the use of octreotide therapy, as well as a retrospective study on the use of omega-3 fatty acids. Before I talked about the octreotide study, I wanted to highlight this really nice table. Dr. Sarah Stroud out of Johns Hopkins gave a really great talk at ISHLT summarizing some of the current literature available on all of the pharmacologic agents used to prevent primary and recurrent GI bleeding. I thought this table really nicely summarized some of the current data available on octreotide use in this patient population, which you can see all of these are limited to small retrospective study, with the biggest cohort here being about 50 patients from the 2017 study. You can also see nicely in this table that the results do vary between these studies, with some of them showing no difference in bleeding rate, and some of them do show a lower rate of GI bleeds with octreotide use. So to help further understand the role of octreotide, there was a systematic review and meta-analysis that was presented out of Boston Medical Center, and they aimed at including studies that evaluated the efficacy and safety of using octreotide to prevent recurrent GI bleeds. They included studies through September 2021, and their primary endpoint was the number of rebleeding events. Their secondary endpoint was the number of red blood cell units transfused during the bleed. The authors of this study ended up including 5 studies that met their study eligibility criteria. I actually believe, I think 4 out of these 5 studies were in the prior table that I showed you, but overall this included 261 patients who had GI bleeds. About 50% of these patients received octreotide therapy. You can see that the mean follow-up of patients was between 6 months and 6 years, and that their conclusion after doing a pooled analysis was that there was no significant difference found between patients who received octreotide versus those who did not. The authors also performed a meta-analysis, which you can see the results here on this forest plot, and their conclusion was that there was no significant difference between both GI rebleeding events and the number of red blood cell units transfused in patients who receive octreotide versus those who receive traditional therapy. So overall, the conclusion was that that octreotide may not be beneficial in patients, but the authors do highlight the important point that all of these studies varied in their use of either subcutaneous or IM octreotide. This could have influenced the results, and some of these studies were very heterogeneous. Overall, highlighting the need, I think, to further study this and identify patients who might derive the most benefit from this therapy. Next, a single center retrospective study out of the University of Chicago was presented that evaluated the impact of omega-3 fatty acid therapy on freedom from GI bleeding and freedom from hemocompatibility related adverse events, or HRAEs. This included 75 patients who underwent HeartMate 3 LVAD implantation at their center. Patients were divided into those who received omega-3 therapy versus those who did not. The authors stated that patients received 1, 2, or 4 grams of omega-3 therapy, all at the discretion of the primary cardiologist or physicians. Also, all patients received standard therapy with warfarin and aspirin, although the dose of aspirin that was used was not disclosed by the authors, at least at the time of this presentation. After Kaplan-Meier analysis and Cox proportional hazards analysis were performed, They found that the freedom from GI bleeding was numerically lower in the omega-3 therapy group, but not statistically significantly lower. And the freedom from hemocompatibility related adverse events was also not significantly lower. Additionally, univariate and multivariate Cox proportional hazards analysis did not demonstrate any difference. So the results from this single center retrospective study actually contrast previous results from a study in 2018 that included both HeartMate-3 and HVAD patients, which did show a lower rebleeding rate with omega-3 therapy. So I think this can overall demonstrate that the HeartMate-3 device does have a lower incidence of hemocompatibility related events in general, but I think does highlight the need for a little bit more investigation and larger studies to evaluate the impact of this therapy. Next, I wanted to really quickly just highlight some different posters that were reviewed on various anticoagulation strategies in LVAD patients. First was a poster on a small amount of patients out of Emory University in which warfarin was completely discontinued in some patients for various reasons. And their aim was to assess whether these patients had any pump-related thrombotic adverse events. So this overall included 8 patients with HeartMate-3 VADs. Warfarin was discontinued in 5 of these patients due to substantial significant bleeding, and in 3 patients due to self-discontinuation or noncompliance. 4 out of the 8 patients, so 50%, were also not on aspirin, so they were not on any anticoagulant or antiplatelet therapy. Warfarin was discontinued for a median of 180 days, but the range was anywhere, I think, from the low 40s to almost 600 days. There were no pump-related thrombotic adverse events seen in any patient that was taken off warfarin, and so the authors conclude it may be reasonable to discontinue anticoagulation in HeartMate-3 patients. However, close monitor is obviously warranted, and some deeper investigation is required to understand the long-term safety of this. But I definitely thought interesting because for patients, for those of us who do take care of LVAD patients, we certainly can have a lot of issues with warfarin and anticoagulation. The next poster was a single center retrospective trial of about 100 patients out of the University Hospital Heidelberg in Germany. These patients all had continuous flow LVADs implanted, and they were looking to see the safety of low molecular weight bridging in the outpatient setting. So the efficacy and safety surrounding Lovenox bridging LVAD patients is controversial and sometimes also center specific. So in this single center study, patients were bridged outpatient with Lovenox if their INR was anywhere 0.4 below their target INR, any lower than that, and they were admitted to the hospital for a heparin bridge. They do state that the dose was adjusted to weight and renal function of Lovenox. However, no specifics were given on the actual dosing regimen or weight and renal function cutoffs. As you can see in the table provided here, the incidence of all adverse events was significantly elevated in HVAD patients versus patients who received HeartMate-3s. And patients who were bridged, who had HeartMate-3 devices, did not significantly have high rates of CNS bleeding, CNS ischemic stroke, or pump thrombosis. I don't think that the higher incidence of events in patients with HVAD is very surprising. However, it highlights, I think, overall that bridging could be safe in patients with HeartMate-3 VADs, but there's, I think, a little bit more information that needs to be known and sometimes can be very patient specific. On that note, this poster out of Baylor was looking at the safety of once daily enoxaparin bridging for patients who had HeartMate-3 devices. This was a small retrospective review of 22 patients, and they used once daily therapeutic enoxaparin dosing. The enoxaparin bridging courses could last anywhere from 3 to 7 days. And I thought it was interesting that 81% of the patients in this cohort did have chronic kidney disease, although they did not really specify the degree of their kidney dysfunction. Overall, they found no incidence of any of the adverse events listed here on the screen. And so their conclusion, the author's conclusion, was that they found Lovenox bridging once daily to be safe and effective in HeartMate-3 patients. So I think that this does add a little bit of data to overall the big data umbrella of Lovenox bridging in bad patients, but it does remain controversial and will probably need some more studies before it becomes universal practice. Quickly, and lastly, shifting gears to anticoagulation strategies in other forms of mechanical circulatory support. I just wanted to really touch on this. This product update was not explicitly presented as a study at ISHLT, but it was talked a lot about there, and then this was released shortly thereafter. So I just felt like it was timely to include, although I know not all of us may take care of patients with temporary mechanical support with the Impella. So the Impella system has historically always required a heparin-based purge solution. This can cause challenges for patients who cannot receive heparin for whatever reason. So Abiomed did release this information that sodium bicarbonate purge solution is now FDA approved for use in the Impella system. I think that this can really alleviate the issue of patients have confirmed heparin-induced thrombocytopenia. But there are some issues that have been noted with using bicarb purge that Abiomed has commented on, and seems like they have teased out what factors might increase the risk for that. But this was just a press release that came right after the ISHLT conference. Not sure if that was intentional or not, but I think something pertinent just to know and update on. Thank you so much. And with that, I think we will open it up to questions from the audience.
All right. Thank you to all of our speakers for an excellent presentation and review of this content. We do have a few questions from the audience I want to try and get to before we end today. Our first question from the audience is for Hannah. So in the basiliximab data that you presented, did the investigators comment on how long they waited between doses in patients that were given multiple doses? And how have you navigated this in your clinical experience?
The investigators did comment they did wait 14 days between additional dosing. And this actually reflects how we've been using it here at our center. But I will note that this is something that we're constantly discussing and looking at, because we have noticed the increased rates of rejection during the CNI holidays. So I think this is something that would be interesting to further investigate in terms of timing of redosing.
Awesome. Thank you, Hannah. Our next question is for Rachel. To your knowledge, are any centers kind of going toward this new trend of using a bicarb purge solution as first line in the Impella patients, given all the issues with heparin?
Yeah, so not to my knowledge, at least before that press release came out, I know that it was only, at least it seemed to only be done really rarely if patients absolutely couldn't be on heparin. I am interested, so I don't have a good answer on if a ton of centers are doing it now. I would guess no. My center, we do a ton of Impellas, and even since that, we really still try and do heparin if we can. So I don't think it will kind of replace heparin, only be there if you really have to take heparin out. But I'm interested to kind of see now moving forward the data on using this if you have to get away from heparin.
Awesome, thank you. And our last question is for Olivia. In the data you presented by Contrala and colleagues on mTOR outcomes in heart transplant recipients, did the investigators comment on induction strategies utilized in the study population? And did they identify any differences in outcomes in those folks?
Yeah, that's a great question. Unfortunately, in this study, they didn't include induction immunosuppression in their baseline characteristics, and they did not either comment on what their induction therapy is at that specific hospital. So unfortunately, I don't have that data.
Sounds good. Thank you, Olivia. Any last minute questions from the audience? All right, well, I think that's our time, and that concludes our ISHLT Recap webinar. Thank you guys for joining on a Friday afternoon. Have a good weekend.